Hello, welcome to the Crash Course Medicine video about epilepsy. We'll start off with a few questions to test your knowledge. Question 1. How are seizures classified? A. Location of brain affected and clinical features. B. EEG pattern. C. Clinical features. Or D. Location of brain affected. Pause the video and carry on to see the answer. That's right, A. Seizures can be classified broadly according to the location of the brain affected, and then more specifically by the clinical features of the seizure. More on this later. Question 2. Which of the following anti-epileptic drugs is not first-line management for focal seizures without loss of awareness? A. Sodium valproate. B. Carbamazepine. C. Lamotrigine. Or D. Phenobarbital. Pause the video and carry on to see the answer. That's right, D. Phenobarbital. It is important to be familiar with the common first-line medications for treating different types of epileptic seizures. Question 3. What's the term for post-ictal or post-seizure weakness? A. Bell's palsy. B. Todd's palsy. C. Erb's palsy. Or D. Transient ischemic attack. Pause the video and carry on to see the answer. That's right, B. When taking a history from someone who has had a suspected seizure, asking about post-ictal features such as weakness is very important to establish a diagnosis. Here's the structure of the video. First, we will discuss the definition of seizures and epilepsy, and also the classification of seizures. Next, we will talk about the symptoms expected from the different types of seizures and how to take a history from someone who presents with a suspected seizure. Next, we will talk briefly about the epidemiology of epilepsy, followed by investigations and differential diagnosis. Then we will talk about the management of seizures, followed by clinical examination and OSCE tips. We'll finish with a summary and some questions to test what you've learned. A seizure describes all signs and symptoms resulting from sudden synchronous firing of neurons in the brain. Epilepsy is a condition in which people are more likely to have these seizures. Seizures can be most broadly classified as focal or generalized, according to whether they affect one hemisphere or the whole cortex of the brain. Classification of seizures. Seizures can be further classified according to the symptoms of the seizure. Focal seizures with aura involve the patient experiencing a subjective change in their sensory experience before. Focal seizures are associated with focal motor activity. Focal seizures with secondary generalization are seizures which start with features of a focal seizure. However, as neuronal firing spreads throughout the cortex, loss of consciousness occurs. Generalized absence seizures cause a loss of awareness without a change in muscle tone. Tonic-clonic seizures have two characteristic phases, starting with muscle stiffness followed by jerking of the body. Myoclonic seizures result in brief twitching-like movements. Tonic seizures result in sudden stiffness in the body, arms or legs, and atonic seizures result in sudden weakness in the arms, body, or legs. In focal seizures, symptoms correlate to the part of the brain affected. These seizures do not usually result in a loss of consciousness. The occipital lobe contains the majority of the visual cortex and is responsible for the processing of visual information. Therefore, seizures in this area can cause visual hallucinations or cortical blindness. The somatosensory cortex is found in the temporal lobe and has a role in integrating sensory input. A seizure affecting this area can result in sensory symptoms such as auditory, taste, or smell hallucinations. Temporal lobe seizures can affect specific contained structures such as the amygdala or hippocampus, which can result in déjà vu, a feeling of familiarity, or jamais vu, a feeling of unfamiliarity. The temporal lobe also has a role in the vestibular system, which means seizures in this area can cause vertigo. Focal motor seizures originate in the motor cortex and therefore can cause movement in the limb or face. This type of seizure typically features jerking movement in the mouth or hands. Jacksonian march is a characteristic finding of this type of seizure. It is defined as the visible spread of jerking movement from one limb to other limbs or across the body. It occurs as neural firing spreads throughout the motor cortex. Focal seizures with secondary generalization often present with a preceding aura, as mentioned previously, followed by complete or partial loss of awareness that usually lasts for 1 to 2 minutes. In the period of recovery, that the patient may be confused and may also experience muscle weakness. This post-ictal weakness is known as Todd's paralysis or Todd's palsy. This type of seizure may also develop into a convulsive seizure after the preceding aura. Absent seizures occur particularly in childhood and usually involve a loss of awareness, which may also be described as vacancy for less than 10 seconds. This type of seizure usually does not affect the tone of muscles, however fluttering of the eyelids does occur. Tonic-clonic seizures are seizures that occur in two distinct phases. The first phase involves generalized muscle contraction, which usually results in the patient falling to the ground. This phase may also be associated with tongue biting. This is then followed by the clonic phase, characterized by generalized rhythmic jerking of the limbs. This type of seizure may be associated with bladder or bowel incontinence. Post-ictal features of this seizure include headache, amnesia, fatigue, and weakness. Myoclonic seizures involve a brief loss of consciousness associated with short, sudden, jerky muscle movements of the entire body or part of it. For example, this may present as a twitching of the finger or hand whilst eating breakfast. Tonic seizures result in a loss of consciousness associated with generalized muscle contraction. This is not followed by the clonic phase of tonic-clonic seizures. Atonic seizures result in a loss of consciousness associated with a sudden loss of muscle tone. As a result, the patient may collapse or have a sudden head drop. Status epilepticus is a medical emergency defined as a single continuous seizure which lasts for 30 minutes or two consecutive seizures in which the patient does not recover in between. It has a high rate of mortality, can lead to a rise in body temperature, cerebral edema, rhabdomyolysis, or cerebrovascular failure. Long term, it can result in permanent brain damage if not treated. It should be treated with IV diazepines as soon as possible. The goal of a history where epilepsy is suspected are to rule out other causes that may present in a similar fashion, and also to establish what type of seizure they are likely to have had. The diagnosis of epilepsy is mainly made through the history, so it is very important to get a thorough history of presenting a complaint, including what happened before, during, and after the seizure. The past medical history, medication history, and social history can also provide key information in confirming a diagnosis. Before the seizure, be sure to ask the patient for their recollection of what happened. Also ask any witnesses what happened before the seizure. Ask about changes in the patient's sensory perception or mood, which may suggest a focal seizure with aura, and also ask about certain triggers which can set off seizures, such as strong emotions, exercise, or flashing lights. During the seizure, since the patient may have been unconscious, ask the witness about seizure features and the order of occurrence. For example, stiffening and then jerking. Also ask about the length of the seizure, as this may give you some idea about what type of seizure has occurred. For example, focal seizures with loss of awareness typically occur for 1 to 2 minutes, whereas absent seizures can occur between 10 to 20 seconds. Also ask for features that occur after the seizure. This may help to rule out other differential diagnosis. Weakness, confusion, and headaches are all common features of seizures. Rapid recovery, however, may suggest an alternative diagnosis, such as syncope. Be sure to ask about risk factors in the past medical history which make a diagnosis of epilepsy more likely. Also ask about lifestyle risk factors such as alcohol and drugs, and also medication, which may cause seizures. A positive family history of seizures is also suggestive of epilepsy, especially in the absence of myoclonic seizures. Around 0.7 to 0.8% of the population have epilepsy, with most people being affected at the extremes of age. However, many cases of epilepsy go into remission after administration of anti-epileptic drugs, so the figure may actually be lower. Investigations. Diagnosis of epilepsy is made primarily by the history, so make sure you take a good one. A 12-lead ECG can help to rule out cardiac causes for loss of consciousness, such as an arrhythmia. Blood tests should also be conducted to rule out other differentials. For example, low blood glucose can cause fainting, hypocalcemia can cause muscle weakness, a full blood count can identify anemia, which can also lead to syncope. Other tests to consider include UNEs and renal and liver function tests. An EEG should only be used to support a diagnosis of epilepsy and to help to classify the type of epilepsy. It should not be used in patients where another diagnosis such as syncope is more likely. Brain imaging should be indicated in all patients who have had an initial seizure to rule out focal brain lesions. The most common condition misdiagnosed as epilepsy is syncope, in which there is a temporary loss of consciousness as a result of reduced blood flow to the brain. This may be suggested by features such as pallor or a medical history of hypertension. Other differentials to consider include migraines, transient ischemic attacks, and psychogenic non-epileptic seizures. If this is suspected, a clinical diagnosis can be made by video EEG, in which video records the patients while simultaneously taking an EEG. Psychogenic non-epileptic seizures resemble epileptic seizures but are not caused by electrical discharges. They are primarily caused by psychological causes. Acute seizure management. Most seizures will end sporadically. However, if they last for longer than 5 minutes, then benzodiazepines can be administered rectally, buccally, or IV. Anti-epileptic drugs can be given once a firm diagnosis of epilepsy is made, and most patients will become seizure-free with monotherapy. Once a diagnosis of epilepsy is made, certain lifestyle advice should be offered, for example, a ketogenic diet, also informing patients about restrictions to driving and operating machinery, and also warning them of potentially harmful situations such as swimming. Other treatments for epilepsy include surgery and nerve stimulation. Choice of anti-epileptic drugs depend on age, lifestyle, comorbidities, and type of epilepsy. Levetiracetam and sodium valproate are commonly used in most types of epilepsy as first-line management. Familiarize yourself with first-line drugs for each type of epilepsy and also be aware of common contraindications. For example, sodium valproate should not be given to premenopausal women due to teratogenic effects. Drugs should be started at low doses and titrated upwards. If seizures cannot be controlled with one anti-epileptic drug, then combination therapy with 2 or more drugs should be considered. Examinations will often not identify any signs that help make a diagnosis of epilepsy. However, be sure to conduct a full neurological examination to rule out other differentials. Neurological examination should include motor system, sensory system, and cranial nerves. A common finding in patients who have had tonic-clonic seizures is biting of the tongue, so be sure to check this during your examination. Test your knowledge on the next few questions. You take a history from a 15-year-old female who thinks she has had a seizure. She says she noticed her hand shaking initially, and after that she lost consciousness. When she woke up, her tongue was bitten and she felt weak for half an hour after. Question 1. What type of seizure is this likely to be? A. Partial seizure with secondary generalization. B. Absent seizure. C. Focal motor seizure. Or D. Generalized seizure. A. Question 2. What AED may you consider in this patient? A. Sodium valproate. B. Phenytoin. C. Clobazam. Or D. Carbamazepine. D. Whilst in the consultation, she has a tonic-clonic seizure and appears to recover, then it begins to convulse again immediately. How will you immediately manage her? A. Take an EEG. B. IV lorazepam. C. CT MRI. Or D. Carbamazepine. B. Thank you for watching the video, and we hope it has helped. Here are the references for more reading.